you entered. So I see that you're muted, Dr. Gruber.
Go.
There we go.
Good deal. Okay, can you hear me? Should be good.
Yes, sir.
All right. Well, are you ready to go? Or I just listened to your
Oh,
intro.
we were just saying good morning, and I was trying to get them all to turn their cameras on, and not all of them said they're quite camera ready. But
Uh-huh.
but hey,
A little early in the day here. I get it.
it is a little early.
Very good.
Well,
So, uh,
this is week three of our talk. We did the electrophysiology with the ions last week, and I wanted to give you a little introduction, if you would allow me that.
absolutely. Please.
And I think I made it so you can share, Dr. Landgruber. So I think
Right.
while I'm talking, maybe you can work on that, or you should have access to that. Well, so everybody, last week I told you we'd have Dr. Landgruber talking, Dr. Pierre Landgruber. He's an interventional cardiologist, and he and I have worked together here. He's been helping with the school for my 28 years, and before that, he was our medical director. He was one of the primary interventional cardiologists for Spokane Cardiology, a large cardiology group for many years, then worked for Providence. And now he's working uh, in more of a clinical environment, helping patients stay protected from cardiovascular disease with clinical management. And he will maybe tell us a little bit about that. That's where we are in this part of the career. But more an interesting part that I told my invasives during the history section of our class was Dr. Limegruber got a chance to be mentored by Andreas Grunzig, who changed the world of cardiology. And I think I saw the first couple slides, so I won't step on Dr. Limegruber's thunder. But it's a real pleasure to have you here again, Dr. Limegruber. I keep asking you, this is the 28th time you said yes, and I won't ask you again. So I really appreciate you coming out here and spending a couple hours with us to teach us how the heart really works down at the cellular and then at the functional level. So I'll turn it over to you. Really appreciate you coming out again.
You're very welcome, Darren, and it's always a pleasure every year when I have the opportunity to give a talk. It used to be a little bit more fun in a classroom, of course, when I got to see you all close up and see your face and see your reactions. And now it's kind of hard to do all those little screens that you have to pay attention. I didn't think last year when we did it virtually that we had to do it again virtually this year, but here we are, and we'll make the best out of it. So, having said that, again, thank you, Darren, and I'm going to see if I can share my screen here, and we should be able to do so here very quickly. Okay, so okay, well maybe this one, huh? Okay, I think we are at the point where I can go on the full screen here. Excellent. I'm gonna just remove that remote control here. Let's see. Okay, how do I? Okay, I want to not those. I want to just get rid of this bar on the top there. Okay, here it is. Hide clothing meeting controls. Okay, so we got the meeting controls out of picture. Anyhow, very good. So yes, today I just give you a quick overview. I'll speak a few words on the history that Darren already started, and then we will have two sections, and maybe we can take 5 minute break or so in between, just to kind of stand up and or whatever, move around a little bit. And what I have planned, and as you might see already in some of the slides, is we need to get the connection established as to how the electricity, as you heard in the previous talk, from the action potential, how does that ultimately translate into a pumping function? After all, the heart is a pump. It's very simple organ, but very fascinating and intriguing, organ. But somehow we need to create that connection. Once we did that in the first hour, the second hour will then more focus on how does that apply to the clinics? How does that apply to patients that you will be seeing? In the cath lab or in the echo lab. So yes, as Darren said, I was very fortunate to work with this man, this Dr. Andreas Grinzig. He was German. He was in Zurich, Switzerland. That's where I graduated from medical school, and he really invented balloon angioplasty, which then led to this date, as we still use it in a way with stents, of course, but stents came only later. And this is actually a picture of the very first patient when I'm just going to move those things around a little bit. Hold on a second here. There you go. That who had the balloon angioplasty performed on September 16, 1977. So it's a long, long time ago. As you can see here, this was an angiogram. If you look very, very carefully, you can see where there is a little bit of blockage there. It's a little bit thinner than here and there. This is the left anterior descending coronary artery. And then he has a balloon catheter. It was very primitive at that time. The only way they could see where they were was injecting contrast or dye through the balloon catheter. And if the right vessel showed up, then they knew you were in the right spot. So then they blew the balloon up, as you can see here. And afterwards, when the balloon was withdrawn, the lesion disappeared. So it was very dramatic in 1977 because at that time people had to have bypass and they were in a hospital for 3 weeks and then 3 weeks or 3 months swim in rehab. And this guy was swimming in a pool. His name was Adolf Bachmann. And 40 years later, same Adolf Bachmann, and I had the fortune to have a, take a picture with my wife and I when we had a 40-year reunion with him. And apparently he's still doing well as far as I can tell. The second individual I want to give credit and homage to is my dear, friend and Dr. Paul Shields, who hired me to come to Spokane in 1985. He was here since 1961. At that time, he was the first adult cardiologist, and he was the founder of Spokane Cardiology. He was a phenomenal individual. I just give you a quick little rundown as to all the things that he did as a first in Spokane. A year later, he had the first temporary pacemaker in town. He also had the first DC defibrillator, direct current defibrillator. He performed a transeptal puncture. Look at you guys. Echocardiogram machine has been around since 1963, and he was the one that promoted that. He also did the first coronary angiogram in the state of Washington. It wasn't Seattle that did the first angiogram. It was here in Spokane, and so forth and so on. But what you may not know, and maybe some of you do know, but what did he else did he do? He started your program in 1966, first cardiovascular technology program that started at SEC. Okay, and that was Dr. Paul Shields. And so this guy was still alive. I visit with him occasionally with a cup of coffee. Here's a picture of him in 1968, as he is explaining to a couple of fellows here as to how a heart lung machine works. So the history in Spokane is very, very rich, and I encourage you, if you have a 15 minutes break, you just want to learn more about this town, look at the YouTube video right here listed, the town and the team, and you will get a sense as to why I came to Spokane. I knew a little bit about what was going on here, and I'm happy to be there every since then. And of course, Spokane Community College was taught by Dr. Paul Shields, who then asked me to do it. I guess 28 times I did that. All right, so not so much for our history introduction. Let's go on with what we want to learn today. This is a brief content summary. We'll talk about the anatomy of the cell, some of the basic stuff. We'll look at how the excitation or the action potential or connects with an actually contracting mechanism. We'll talk about a Starling law, which is important to understand. We talk about contractility. What does it mean? What do we mean when we say contractility? And then we want to, of course, look at the clinical correlation in terms of how does that translate into the real world. All right, here anatomy. Here's an anagram that you all are quite familiar with. The basic functions are listed here. I just want to point out a few very important items that's unique to the cardiac heart muscle, and that is, you do have electricity that's conducting, and you have those gap junction through which the electricity connects from one cell to the next. Very important to have a very good connection between each cell so they all communicate with each other. Then, of course, since we line up in series, cell after cell after cell, that's how we create a long line of contracting elements. It's critical that those cells are connected very tightly with intercalated disc and desmosomes that keeps them together so don't they break apart and rupture. The third one I want to point out to is this tiny little dot here. It may look like fairly, it's small and really not important. But if you look here, this little tube here, it's called a transverse tubule that creates connection from the outside, deep inside this muscle bundle here. So to be sure that as the action potential travels along the membrane, there is means of that actual potential to penetrate deep into the cell and send the signal inside the cell of depolarization that then leads to calcium release, as we will see into the cell here in a minute. So, of course, every cell has a membrane, has a mitochondria, has a nuclei, and of course, most importantly, the active contracting filament, as we'll see here in the next slide. Here's a little bit blow up of this myofiber. You have the membrane, you have a sarcoplasmatic reticulum. If you look very carefully, you see how this sarcoplasmatic reticulum is very strategically oriented at the plasma membrane here. And then, of course, here we also have plasma membrane, but it's through this T tubule, those transverse tubules. And to me, it looks like, in the old Wild West when people put their ears on the railroad track to listen and see if a train will be arriving here pretty soon. That's exactly why the sarcoplasmatic reticulum is oriented close to the plasma membrane here in the tubules and, of course, on the outside. As we will see, the sarcoplasmatic reticulum has calcium stored, and that calcium is absolutely necessary before we can see a mechanical contraction. Here you have the cell displayed as from the microscope as it sees it, and you have what's called Z line on each side, and you see how this cell is in diastole, in a relaxed state, and as doing contraction, it gets shorter. We will talk about the myosin filament with the myosin head that then form cross bridge with the actin filament here. This will be the actin filament, and we will tighten pressure sensor. So those are the main element. Of course, we have calcium channels. We have a sodium, potassium, and calcium pump, and we will need to understand what exactly they do. But this is what's unique about the heart muscle. Sarcoplasmatic reticulum, calcium, membrane, all located and organized. I'm going to show you the next slide. Okay, so those are essentially the element that you want to remember: the sarcolemma, membrane, transverse tubuli. Why we have tubuli? It's to connect with the center of the myofiber, sarcoplasmatic reticulum, where calcium is stored. Okay, and all those elements that you're quite familiar with. We have the mechanical connection, we have the electrical connection, actin and myosin contractile element. I think it's pretty clear. You're all familiar with that. I just want to refresh that so that we know when we go on to talk about what's happening here. So this is the action potential, as Darren explained to you, and you have a basic the membrane potential is a minus 90 or 85 in this slide millivolts, and I'm not sure I want to go into detail too much, but I want to see if I can explain why is it 85 millivolt. And I think it's a little bit hard to ask question of all of you, but essentially it's because potassium can freely move through the plasma membrane. Okay, that's the only one that can float through. And so what does that mean then? Well, think about it. Every time a potassium element, moves from the inside to the outside, it leaves a vacuum inside the cell. Well, the vacuum leaves a negative hole. So potassium keeps going out, keeps going out. As more and more potassium goes out, there's so much negativity here inside the cell that the potassium is now pulled back like a magnet. The positive potassium electrode is now, is not able to pass to the membrane. That's what creates that potential. Anyhow, enough of this. You heard that last time. But as the cell depolarize from this minus 85 millivolt, it is because positive sodium is able to rush inside the cell. And then, more importantly, during phase two of the potential, you have calcium that, excuse me, calcium is moving in. So calcium is the main electrolyte at that moment that plays a role. That's one of our focus. And then, of course, you have repolarization and they have basic, you know, basic membrane potential at rest. Okay, so let's see what happens as the cell depolarizes. As you see on this slide, if you look carefully now, the inside is positive and the outside is negative. In other words, this cell just has depolarized. Normally, inside is negative and outside is positive. So this condition here reflects as the cell is depolarized. At that moment, as that depolarization occurs, you have calcium channels here, L-type calcium channels, they open up and calcium is allowed to rush inside the cell. Of all the calcium that comes into the cell, about 20% comes through those channels from the outside. Calcium also allows to enter the cell and then it triggers the release of calcium, calcium-induced calcium release from the sarcoplasmatic reticulum. In fact, if you look carefully, the majority of the calcium that is going to be available for the contraction does not come from the outside to those calcium channels. It comes clearly from within the cell where it's stored in the sarcoplasmatic reticulum. Okay, so there are special channels that release that. I don't want to bother you too much, but remember, the majority of calcium comes from within the cell, within the sarcoplasmatic reticulum. It's that release of that calcium, however, is triggered by the entry of calcium from the outside during the depolarization phase. That's an important concept, and you want to remember that. Here's a bunch of busy slides here. I don't want to bother you too much, but it simply reflects what I just said. On the left side, you have the resting condition. Those little red dots represent calcium. You know, you have the T tubules here. You have the myosin actin filaments. Very few calcium are free in the sarcoplasma itself. Okay, now we have the membrane being depolarized. You have an actual potential that runs down the entire length of the heart muscles. And now you can see the calcium channels open and those little red dots are calcium allowed to enter the cells. Now they're freely out there. At the same time, they also come out from the sarcoplasmatic reticulum. That's what the little square here looks like. And we have calcium now attached through the myosin actin contractile element. And of course, you see that the width of this cell here is now much shorter. That's why we have a contraction. And then, of course, now the job becomes, well, that was easy, but just, unload that calcium inside the cell. And now we got to figure out how to get rid of that calcium so that the next heartbeat is able to reoccur. So we have to get rid of the calcium. The channels are closed. Now we have to pump this calcium back into where it was, which requires, of course, energy. So this is what this slide represents. We'll talk about that one few more times here just to make sure you fully understand. Now we have a little bit blow up of that same contractile element, myosin with the myosin head that then forms a cross bridge between the actin. Here in yellow, you have an actin filament. And then you have this green line, which is kind of like a spaghetti, if you wish, that's wound around the actin filament. And then every so often you have what's called a troponin complex, this little green dot here. There's one here that represents the troponin complex. This green line is called tropomyosin. Okay, so let's see what happens as those elements start working with each other. It's a very well orchestrated process, and it's all started by having calcium around. Okay, here's what happens. When the actin and myosin interact. At rest here, you have the myosin head. ATP is located at the tip here. Actin, you have the tropomyosin that winds around to the very tip of the actin filament. And calcium then obviously joins and see what happens when calcium moves into the cell in enough concentration. All of a sudden, the calcium binds to the troponin complex here and here. What that allows then is to move that tropomyosin away from the tip here, away towards the center of the actin. By doing so, it frees up the area here of the actin that the myosin head is looking to connect with. Here, that head is not able to connect because the tropomyosin blocks it. As the calcium binds to the tropomyosin, it has a stereochemical reaction and pulls it to the center. Now the myosin head can interact, and that is all it requires, other than, of course, using ATP that is then split into ADP and phosphate. That process requires energy, and that's all. That's it. That's the heart pump right there. You follow me? You ask me what? Well, let me see. I show you. Look at this line here, 90-degree compared to the myosin. That's at rest. Now see what happens during the contraction right there. The line is now tilted towards one side. The tiny little tilt to the left, the tiny little kink, so to speak, in that myosin head. If you multiply that with million cells, you can imagine what happens. I'm sure you all have played with ropes where you have children holding hands with each other, long line. And if everybody moves one step towards the other one in the middle, what happens to that to the kid at the end of the line? Well, he's going to have to run just to catch up. This is how much movement is happening if one cell does this minuscule little tilt of the myosin head. At the end, we have a whopping motion of the heart muscle that is finally able to pump blood. That's really what we want. The heart has to pump blood. So once you understand that concept, it's pretty easy. And here we have a cutout. We're looking down the barrel. What you saw here before, I'm going to cut across, and it looks something like that. You have the actin, our little blocks. We have the tropomyosin spaghetti is now a circle. And I will spend some time on the troponin complex. This is the troponin complex that consists of three elements, the troponin T, troponin I, and troponin C. Very easy to remember. The troponin T is attached to the tropomyosin, hence T for tropomyosin. The troponin C is this molecule, or this protein complex that binds to calcium, hence troponin C. And the troponin I, as you can see here, is inhibiting the interaction of the myosin head with the actin, and hence it's called troponin I inhibition. Now calcium binds to the troponin. See what happens? The tropomyosin is pulled towards the center. So it's pulled towards the center. And as it is so pulled to the center, it gives up the area here on the actin where the myosin is trying to find a connection. It's trying to build that cross bridge. And that cross bridge, as we just saw, of course, leads to the mechanical motion, the slight little movement that ends up being a systolic contraction of the heart pump. Okay, why are those important? Because those proteins, or those markers, are ubiquitous everywhere in medicine, in cardiology in particular, where we can identify if there is a problem with the heart cell. For example, if you go to the emergency room and you tell the emergency room doctor you're having chest pain, the first test he will do, the first blood draw he will do is what? I think you all know, he's going to measure a troponin. That's the baseline. If your blood has troponin floating around, that means, holy moly, somewhere there is at least one cell. Nowadays, it's so sophisticated and highly sensitive that broke down. And as the cell breaks down, these troponin markers are released into the bloodstream, and we can measure that. It wasn't until the last 5 or 8 years that we have that. It was very cumbersome in the past to figure out who has a heart attack or not. EKG used to be for a long time the only thing. I remember those. And then later on, other markers and enzymes and so forth. But nowadays, the troponin is very specific for the heart muscle. There's no other muscle like skeletal muscle that has troponin. If troponin is in your blood, that means, at least one cell has died. Of course, it becomes a clinical then decision how high the level of troponin is, the higher the worse. So that's why I want for you guys to remember what is troponin, where is it coming from? Okay, and here's just a little video, it gives you an idea. Again, we have those heads that twist, and as you can see, as they move, that we have somewhat of a mechanical contraction occurring. It's kind of cute little video. I'll show that. Anyhow, so now we have a problem. I mean, the problem is What are we going to do with this calcium in the cell? Somehow this calcium has to disappear back to where it came from. So that, oh man, that's going to require a little bit thinking how we're going to do that, and it requires energy, as you see on this slide. See, you have ATP, ATP, ATP. ATP is energy. So a lot of energy is being consumed during the relaxation. It's kind of hard to think, I mean, I always thought that, well, contraction, that requires energy. It turns out, yes, it does. We saw the ATP is consumed as the myosin head connects with the actin, but even more so, energy is required during the relaxation. In fact, those of you who do echo, you will know that the first thing that a heart muscle that's in trouble will show you when you look at it how it contracts. It's not the contraction part, it's the relaxation part that becomes abnormal. One of the first signs. That's why, because energy is a problem, energy supply is a problem, it's a failing heart. So we will see diastolic or relaxation issue. Let's just go to this slide together. As you remember, 80% of the calcium came from the sarcoplasmatic reticulum. Well, 80% has to go back into the sarcoplasmatic reticulum. That's the sarcoendoplasmatic reticulum calcium ATPase. It's just a fancy term that this little enzyme here that is AT has to pump calcium back into the cell, which requires energy. It's pushing it up the gradient, pushing it against the concentration. Phospholamban is the enzyme that is controlling that step. Okay, phospholamban is a facilitator or inhibitor of that process. Don't forget about this calsequestrine. But now you're left with 20% of calcium that has to go outside because that's where it came from. And so calcium is being pushed out again through an ATP energy consuming pump, 5%. 15% turns out that is sort of free. It's a freebie. It's a bonus because calcium does not require energy to leave the cell, but it requires sodium to be exchanged. For one calcium molecule, for one calcium electrolyte, we need three sodium to be entering the cells. It's the only way that see that moving door, is able to get rid of the calcium. So if free calcium come in, calcium can scoot out like a revolving door. Well, so that's good enough. So, but then all of a sudden we have sodium here inside the cell. Do we want sodium inside a membrane that's in the resting phase? You see, it's negative inside. Mm. I used to be able to ask you that during the class, but I'm sure I'm just going to give you an answer myself. But unless somebody wants to chime in and unmute yourself, of course, we do not want to have sodium inside the cell. We want potassium inside the cell. Well, look what happens. Luckily, we have what's called the sodium potassium ATP pump, sodium potassium pump. There's a pump that takes care of this problem. So we have more sodium here, no problem. We'll just pump it back out and I'll bring the potassium back in where it needs to be. Okay. But yes, this process requires energy. That's why we're burning ATP here. Okay. So that's how the calcium ultimately gets pushed back out. 80% sarcoplasmatic reticulum, 5% with ATP, the other 15% a revolving door with sodium. And then, of course, we got to fix the problem with too much sodium inside the cell by activating the sodium potassium pump to reverse that inadvertent increase of sodium to push the sodium outside like it's supposed to be in the resting phase and potassium inside like it's supposed to be. You all follow me there? If anybody has any question, please interrupt me. Unmute yourself and ask the question. I'll be more than happy to answer it. Okay. All right.
I do have a question.
Yes, please.
This is Nancy.
Nancy, very good. Go ahead.
Uh, can you please talk more about phospholabam? How does the 80% goes out with that? Is it a pump at all? Is it just
Yes,
exchange?
yes, it is a pump. It's not an exchange. As you see, ATP, adenosine triphosphate, that's an energy molecule. As ATP gets split into ADP, it releases energy and phosphorylates that enzyme phospholamban here that then facilitates to actively pump. It's not just a channel that opens up. A channel that opens up releases electrolytes according to the gradient. Here we have to push it back up against the high gradient. There's a lot of calcium in here. So we really have to push it, we got to shove it back up there. Phospholamban is the enzyme that is activated according to catecholamine supply cyclic IMP in particularly. And we'll talk about that in a minute. I just want to throw that in there. But it is the rate limiting step that can be influenced. So it's kind of like a facilitator to get that process moving. Does that kind of answer your question, Nancy?
It does, yes, thank you. One more, what does
Yep.
CIRCA stand for?
Okay, it's sarcoendoplasmatic reticulum. Okay,
Oh, okay, I get that, thank you.
calcium ATPase. It's a long word. That's why it's. I'm not sure that Darren will ask you that, but he certainly will ask you that energy is being used to get back into this, sarcoplasmatic reticulum and ATP being consumed. Right. Very good. Good questions. So here's a question for you now. Since you asked me a question, I'm going to ask you a question. All right. So the question is: digoxin is a drug that inhibits sodium potassium ATPase pump. Okay, and of course, digoxin, you may or may not know, but digoxin is a drug that we used for more than 100 years. It was one of the first heart medication. People who had heart failure, we would find the foxglove flowers and grind them up, and then have people drink that or the tea or whatever, and they would feel a little bit better because it blocks the sodium potassium ATPase pump right here. So why is that supposed to be a heart helping drug, or heart failure drug? Okay, so here it is. We're going to block this pump. Now we got to do this whole slide all over again to figure out, is that a good thing to block this pump, and how is that going to help us? Okay, well, the answer is number one, as you block this pump, what happens to the sodium inside the cell? Sodium inside, anybody can hear me? Are we good? So, okay. So sodium inside the cell goes up or goes down? Anybody can chime in. Up goes up.
Goes up.
Now we now we have more sodium inside the cell. It's like, dang it, I don't want that. I want potassium inside. Well, let's just go next step. So if sodium, number two, if sodium is more prevalent inside the cell, so this process over here, will that improve or will that slow down in terms of getting rid of the calcium?
Gets rid of more calcium.
Okay, so if there's a lot of sodium in here, as we just did here by blocking this, we end up with more sodium in the cell. There's a lot more sodium in the cell. What does calcium require before we can leave? Remember, we want to get rid of the calcium in the relaxation phase. So the calcium, before it can leave, it has to wait until the sodium is ready to move in. If there's no sodium moving in, the calcium cannot move out. But now look what happened. We have a lot of sodium here. So the sodium outside say, man, I wish I could come in, but they're telling me we already filled with sodium. Sorry, guys, cannot come in. Okay, that's what sodium is being told. Well, how is that help for the calcium? The calcium said, wow, bummer. I cannot leave until some sodium moves in. So calcium is reduced. Calcium is able to leave the cell during relaxation with this initial process here. Calcium is not finding a sodium to move in because there's so much sodium already in the cell by blocking this pump that the calcium is now not able to go. You follow me? And so that is what's happening. So intracellular calcium increases. And then, of course, now we've got it. There's more calcium inside the cell. Is that a good thing for the contraction for the next one? Yes, it is. So contractility is the term that we use, increases. The heart is now able to pump a little stronger. You see that process? Now, having said that, you may imagine that's not always a good situation either. I mean, it's why digitalis is a dangerous drug. If we keep giving too much digitalis, oh man, the whole electrolyte balance is way out of helter skelter. Membrane potential drops down from minus 90, now it's down 80, 70. Pretty soon we have a major electrical disaster. We have lots of arrhythmias, and people can die from too much digoxin. It's a wonder how in the old days they just grinded up a few leaves and, well, just take one leaf, one half leaf or whatever. And, I mean, it's amazing how the old 150 years ago, doctors were tapering that. Anyhow, so digoxin increases intracellular calcium by blocking the sodium potassium pump. The resulting excess sodium inside the cell will now inhibit calcium to release because not enough sodium is able to enter the cell. Hence, the calcium is waiting and waiting and waiting forever for sodium to come in. Well, that waiting it does inside the cell increases the intracellular calcium and contractility goes up. I hope this slide explains that. If somebody has a question, please, again, unmute and move in. I want to move a little bit to a different situation here. Let's see if I can move my picture here out of the way here. How do I do this? Ah, so this way, huh?
So Dr. Limegrove, these two slides that you have here really help explain a whole class we taught on pharmacology and how things really work, beta blockers and digitalis.
Right. So
Kind
they
of loops our farm back together nicely.
And this slide here is what summarizes it. Thank you, Darren, for saying that. And I want to walk you through this because it's critical that you all understand. This is probably one of the most, in my opinion, important one. It is how can we modulate the heart? It's one thing giving calcium, boom, it goes. But wait a minute, and if I'm sleeping at nighttime, I just want a little contraction. If I'm around doomsday, I want a little bit more contraction. So there's a way the heart is being modulated as to how much contractility, how much power it generates. Okay. So what is necessary for that? And that is those beta receptors. Beta receptors are the receptors where the catecholamines, norepinephrine, binds to the cell membrane, and then a whole host of reaction happens after it binds to it. And the basic one is the adenyl cyclase enzyme that changes the GTP into cyclic AMP. Cyclic AMP is a ubiquitous intracellular messenger that has a lot of function. I'm going to show you some of those functions the cyclic AMP has once the catecholamine attaches itself to the beta receptor on the outside of the cell. First of all, cyclic AMP does what? Look here, metabolism, lipolysis, citric cycle gets activated. Why do we have to do this? Well, guess what? This is our furnace. We need heat, we need energy. So we need to burn glucose, we need to burn fat, we need to convert the citric cycle, the fat into ATP. We need ATP. So that's what cyclic AMP does. And as you see in this slide, ATP is necessary for our contraction between actin and myosin. Furthermore, cyclic AMP does what? It phosphorylates our calcium channels. Now the calcium channels are even more effective in letting calcium move into the cell. So it improves the influx of calcium. Furthermore, of course, as the calcium moves in, we have more calcium released, again, more calcium available, more contractility. So it's one thing in improving the calcium being abundantly available, but you can't just do one side, you got to do the other side too. And the other side being, if you facilitate the calcium increase, you have to facilitate the pushing back the calcium in the sarcoplasmatic reticulum. That's what cyclic AMP precisely does. Cyclic AMP via phospholipid bond increases the reabsorption of calcium, so to speak, into the sarcoplasmatic reticulum. The end result is here on this particular slide. You see one contractile function of the heart. This will be the lower one here. This is the normal, pattern of how the heart contracts at sleep time. Now where we have catecholamine on board, you see the difference. Much faster it increases. This is sort of sluggish going up and then sluggishly going down. Well, here it goes very swiftly, and it goes to a much higher level. Okay. And then, of course, it also relaxes much faster. Okay. And so this is what the beta function does. It increases the rate of contraction, heart rate. So the peak force is increased, and the rate of contraction, the slope of this, how fast it is. And then rate of relaxation. This is what beta receptors, beta catecholamines do in terms of the heart function. Troponin C is also activated. Look at that. Sometimes troponin C only binds sluggishly. As soon as you have catecholamines aboard, The troponin C is hungry for calcium. It just really snaps onto that calcium. And of course, then you have more contraction. Well, so it's a very complex mechanism, but the bottom line here for all of you, better adrenergic stimulation increases contractile function, increasing heart rate, increasing relaxation. This is exactly what we need in order to keep the heart going slowly, going fast, going stronger, going weaker. So this is our way that we monitor that. Okay, so this slide will explain it to you very easily. The question is, what is the catecholamine effect? What is the digitalis effect? We just talked about that. Calcium blocker. Well, we use medications for blood pressure called calcium blockers. If we use those blood pressure medications, we will have a result where calcium is not going in as fast, the heart rate will slow down, the blood pressure goes down, the heart contraction is obviously diminished. Same thing, obviously, but beta blockers, if you block those beta receptors, you will have a negative function on the heart. Okay, forget about the other busy slides, essentially was in the previous one. Okay, so summarizing our excitation contraction coupling, we are aware of it that the sarcolemma, the membrane, is where action potential is being conducted under the tubules. We have our calcium channels that let this potassium come in 20%. It then stimulates the release of calcium from the sarcoplasmatic reticulum where the calcium is stored. We understand the importance of calcium. We understand the cyclic AMP as a messenger where the beta receptors tell the heart cell to move on and contract better. We understand how the digoxin works via sodium blocking of that sodium potassium pump. We know the beta adrenergic effect. We know active filaments. We also know that everything requires energy, relaxation actually more than the contraction. And we understand tropomyosin, troponin complex, how that's being used to assess if a heart is a patient that comes into the emergency room has a heart attack or heart damage. As if that level is too high, we conclude from that there is some damage being done on a few heart muscle cells or a large portion of the heart muscle, of course. Okay, so hopefully we can move on. If there's still a question on this basic mechanism, let me know because I'm going to move on now to uh, the uh, the more clinical phase of the heart. Okay. All right. So just for you to understand, this is a slide I just put in because it just came out November 13, 2020. So I did not see that before. And there was a study called Galactic Heart Failure. New myotropic drug class shows modest heart failure with reduced ejection fraction benefit. Let's just look at the slides. So look at here. You have your myosin head, actin over here, thin element here. And you see one, two, three of those heads have make connection. Okay. Once you give that medication, this omecamtiv mecarbil, you see now one, two, three, four, five, six of those are connecting. So you imagine that this heart works a lot better than this heart. Okay. So that's what I wanted to show you. There's actual drugs now that I'm sure you all will see that will have a direct effect at this level that we just talked about, actin myosin interaction. And that's a fascinating drug and especially makes sense as for our talk today, of course. Okay, moving on. Frank Starling law, and you will hear that term used a lot when you work in a cat lab and others, and it's not Frank like Frank Starling, that's first name, last name, that's with two different individuals, Otto Frank, German guy, and Werner Starling, an English fellow, and they were working on the heart function. And they both came up about the same time with their findings that the heart increases its stroke volume. I'll explain that in a minute. Essentially, the function of the heart is increased in response to increased end diastolic volume. That's all they did. They didn't have anything, microscopes or anything to measure Z line and so forth. But they could tell that if we stretch the heart a little bit more, we get more function of the heart. And I just, sorry, I need to move my little pictures out of the way here. I don't know how to do that. Let me just do this, something like that. Okay, now here we go. Now I can move there out of the picture. Okay, so instead of end diastolic volume, which also is termed preload, which I will all explain in a minute here, I use end diastolic sarcomere length, the length of the cells that we just talked briefly before. It's the same means left ventricular end diastolic pressure. So volume, pressure, sarcomere length, they are all interchangeable for this concept that I want to explain to you in a minute here. So what does it mean? So the heart increases its stroke volume in response to end diastolic preload, all factors being equal, you know. So just accept that for what it stands. This is what they came up with. Okay, I'm going to explain to you what the Frank-Starling law means for us who we understand Z-line, we understand actin, myosin, and we have our myosin heads here. Okay, so this is that this length from the Z-line to Z-line of this one cell is about 2.2 microns. Okay, so at this moment here, if you look carefully, you see those myosin head, we have a total of 12. Okay, 8 of them making very nice connection, but those two guys here be wasting those two fellows here, no? They have no actin to interact from this myosin head. So you say, huh, that's not good. Let's just improve that. Well, how can we do that? Well, we can shorten that. We push that together. Well, now, yes, we all of those 12 myosin head, now they're having perfect connection with the actin. They are ready to start pulling on that rope and making good contraction. Yes, but you see here, now the cell width is only 2.0 micron. They're really short. How far can they go? Well, they're going to bump into each other, those actin filaments, very quickly. So yes, we have more myosin head connection, but we have no way to go. That's that's why the stroke volume or the function of the heart is dropping. So he said, huh, well, I can fix that. I'm going to just stretch it a little bit more. Well, yes, you can. And now the problem is, yes, you can slide a whole lot more here at this length of 2.4 microns, but now all of those 12 guys are just floating in the breeze. They don't make any more connection. You can easily tell me that you understand it, that this condition here, that's not good because the stroke volume is going to go down. If they're not connecting, if they're not pulling on this on the rope here, there is no action going on here at all. So you see it somewhere in the middle. Somewhere in the middle is the optimal length. Between 2.2 and 2.4 micron is where the heart works the best. And that's what Frank and Starling, figured out that between those two lines, if I stretch a little bit more, the heart improves. If it goes down, the stretching, the function goes down. That essentially means what Frank Starling is. I can plot this findings out in a graph, okay? And this is what the graph looks like. Here we have the length, sarcomere length, 2 to 2.4 micron. I can transplant that to end diastolic volume in the heart, the left chamber, left heart chamber, left ventricle chamber, 70 to 110 milliliter. Or I can also use pressure instead of volume. It's easy to measure. We can measure pressure very easily in the cath lab. Very difficult to measure volume, of course, we don't measure sarcomere length. And here we have the force of contraction. So you see between 2 and 4, 2.4, that force increases to the point and then it starts dropping off. Here it decreases, then that drops very much off below 2. And that same thing happens in diastolic volume and pressure. So we end up this J-shaped curve. Remember that Starling law has to do something with a J-shaped curve where there is both sides that where the function is decreased and somewhere in the middle is an optimum like a J looks like. Okay, moving on. So anybody have question with the Starling law? Please chime in. Feel free. Okay. All right. I'm gonna move you guys on the side. Good. So I don't hear anything, so I presume we've got it covered here. Moving then on to contractility. What does that mean? Contractility, the heart has the capacity to develop different forces of contraction at the same preload or measured or expressed also end diastolic sarcomere length, end diastolic volume, LVEDP, left ventricular end diastolic pressure. The heart has a unique property to be better, even though we just learned from the Frank Starling at a certain length, a certain volume, the heart has X contraction. At another level, the heart has another level of force. But now I've just told you, start all over again. Don't think too much. Okay, let me see what I mean. This is what we just saw from the Frank Starling. 2 to 2.4, 70 to 110, something, those numbers of end diastole before the contraction occurs. How much stretching the heart has been undergone determines what the force of contraction of the stroke volume is. ends up like this. But now contractility means this. If I'm here at 2.0, yes, I'm getting this force of contraction, but now look at this. At that same length, all of a sudden it's way up there. And here in the middle, way up there. Everything is improved. So what the heck happens here? Why is this force of contraction at the same length? We just learned that's the optimal 2 to 2.4. And I can expect to see this kind of a force. And all of a sudden you're telling me, well, no, I can double that. Interesting. Well, we talked a little bit as to how the heart modulates its force of contraction. It has something to do with, did anybody say, with what kind of drug or what kind of a
Beta.
beta receptor? Very good. I know the improved contractility is called positive inotropic effect. That's Greek. Inotropic means strength, that positive strength. Okay, and catecholamines, you're absolutely right. We mentioned it. And the same thing with dopamine is one of them. Digitalis will be, it's not a catecholamine, but it's one drug that improves that with the same length. It improves it, it increases it or doubles it. Well, the same corollary, of course, if it's reduced contractility, then of course, at the same length, now we are not doing well. The contraction is even lower. Of course, that happens when we give beta blockers, when we give calcium blockers, when the patient has heart failure. Patient that's heart is very weak, you will not see this kind of contractility occurring at the end diastolic pressure of 5, much, much less, half of that. Okay, it's because a patient who has heart failure, most often, they have damage to their heart muscle by having had a heart attack, where there's a big portion of the heart that is destroyed from a heart attack. So now you have much less contraction occurring, of course. Now, as I make this as a pressure, left ventricular pressure, now I'm changing it towards time, in seconds, and here still we have pressure. So we have a left ventricular contraction. The reason I bring this up, because that's what it looks like in the cath lab, for those of you who will spend, a lot of their time alive in there. So we see how quick a normal yellow heart, this is the contraction and relaxation. We'll talk more later. And now in the green one is the one that has positive inotropic effect. You see how fast it goes up, and see here the heart failure patient goes not nearly as fast. I'm going to blow that up a little bit for you. Now it looks something like that. Okay. And what I'm really interested to know is in a specific time interval from time here to time there. And I call this delta. This little space here is a delta space, delta time dt. I'm interested to see how much does the pressure or the contraction change in that time interval for the green one. Well, the green one, the pressure here at this time is like that. At the end of the time interval is that high. So this is our dp. This is the change in pressure. In contrast, the purple heart here, in that same time interval, the pressure goes from here all the way to here. So the dP is shorter. You see? So dP divided by dt, change in pressure over change in time. For the green heart is very good, it's high. For the purple heart here, it's definitely reduced. That is what you will measure in the cath lab. It's special catheter, high fidelity catheters, where you can look at pressure changes. You can also measure with the echocardiogram, as you know, in diastole, negative dPdt, and it gives you an idea as to how quickly a heart relaxes. And that's a healthy heart versus one that has trouble relaxing. We measure dPdt. Okay, so that's all I have for the first hour. I was thinking maybe a 5-minute break. Okay, coffee break, and then we convene here at I have at 8:30, and we'll go over to the more clinical part. Does that sound right, Darren? And
Yeah, that sounds great.
okay.
Good start. Now we know what goes on inside the cell.
So now the rest is easy. So now we just all sliding home here. The first
Put it
one.
all together. Yeah.
Very good. Okay, very good. So I'll see you shortly here. Let's see how I can find my controls here. Stop sharing you real quick, and then I'll be right back.
Well, wouldn't it be nice if we had Dr. Limegrove every day? Then we could learn so much more. We would really have a deeper enlightenment of medicine.
Hey, okay, I think I unmuted myself. Mhm.
Yes, indeed.
Okay, see if I can. I never know how to move that. I get those. I just have you down, unfortunately. Fortunately. I can only have so many pictures of you all, otherwise my whole screen is filled with all those young people there listening. So everybody doing okay, by the way? Did you stretch a little bit and shake off and relax? And now we're going to go to the fun part. This is the real deal, the part two. Anyhow, yes, I used to be with Spokane Cardiology. Now what I do, I just said hello to my team here. I'm working in an office where we have where we see patients before they get to the cardiologist office. We hope, or maybe they never have to go to the cardiologist. They never have to go to the emergency room with chest pain. I'm doing preventive cardiovascular disease. And people come here who say, well, my brother had died at 50 of a massive heart attack. I don't want to have the same thing. And lo and behold, if one looks very carefully and with a very specific, very organized, methodical approach, you can pick up folks who are heading in the same direction, and we can help them. And I'm very, very excited. I used to be really not to be too cozy, pumped up, and I did a nice talking about the cardiac pump. Oh gosh, when I did a stent and people did well, and patient was able to get out of the hospital quickly and stopped him from falling over the edge. And I miss that. Of course, it's a wonderful job to be able to do that, but this one comes very close when you can tell people if you do what you do and you watch them, you follow them for years, and you can see they really changed their pathway. They really came to a cross in their lives, and they decided, I want to go that same path as my brother. I want to change it. I want to go. I'll do everything I can, living well, exercising, eating right, watching my blood pressure, my cholesterol, my sugars, and so forth. I think I have a fighting chance, and they do. So that's what I'm doing now: preventive cardiovascular disease. Okay, move on then. Here's another diagram of the heart. You see that, but I'm going to focus on the left side of the heart with the mitral valve, the aortic valve, and then we have the tricuspid valve, pulmonic valve. Let's move on to this one here. Here you have a heart in diastole on the top, here in systole, looking from the head on down towards the feet. Here's the tricuspid valve, and here's the mitral valve. During diastole, that valve is open, the blood rushes into the right and left chamber. The aortic and pulmonic valve on top are closed. And of course, as the heart contracts, those two valves have to close and those two open. We're just going to go through that. Okay, so I want to walk you through. And here on you have the pressure on the and y-axis and x-axis, you have time over time and pressure. Okay, the black line here is the aortic pressure, and the red line is the left ventricular pressure, and here you have the left atrial pressure. Okay, we'll leave it at that for now. Down below, you have the heart sounds. A for atrial sound, as the atrium contracts, it creates a little pressure here as the atrium contracts, and then the ventricle contracts, as we all know. The first heart sound is created by the closure of the mitral valve, and the second sound by closure of the aortic sound. Then you have a third heart sound that is abnormal in adults. Sometimes in young people it's not. And then we have the EKG here. As you can see, the R wave of the EKG signals the beginning of the systole. You can always find the beginning of the systole where the R wave is. And then QRS complex, as you are familiar with, and the T wave repolarization. And then you have the resting phase until the next P wave. And then the P waves is what then signals the beginning of the atrial systole. Okay, so let's see what happens here. During the atrium contraction, the valve is open, mitral valve. The pressure that's being generated in the atrium is transmitted very equally without any obstruction, unless you have a valve problem. Let's forget about that, but it's to right here. And then the ventricle starts to contract. Now the pressure in the left ventricle starts to rise to the point right here. Pay attention to my little arrow here. At this point, the pressure in the left ventricle exceeds the pressure in the atrium, and that results in closure of the mitral valve, and that creates the sound. Follow here. The pressure increases in the left ventricle. Mitral valve is closed. The aortic valve also is closed. Here, the pressure in the left ventricle exceeds the pressure in the aorta, aortic pressure. Now the pressure is again the same aorta and ventricle. The volume of blood is expelled, and then at this point, the heart stops contracting. It's getting into the relaxation phase, and then the pressure drops below the aortic pressure, and the aortic valve closes, and that's why we have the second sound. The pressure continues to decrease, and to the level still higher than the left atrium, but now it falls below the left atrium. And now the pressure is higher in the atrium than in the ventricle. Now the mitral valve opens and the blood flows into the left ventricular chamber fast at first, then, excuse me, and then a little slower. And then we have the next cycle. You understand? Excuse me. So that's kind of what we're going to start talking here in a minute. And let's go to the question I have. What is the arm blood pressure on this patient? The reason I'm asking that question is because the blood pressure has, what we typically know, systolic pressure, diastolic pressure. Can somebody tell me approximately what it is? You may have seen the slides from last year, but I'm just going to move ahead. Obviously, up here, that is our, that is, hold on a second. That is our systolic pressure right there. Okay. Here is our diastolic pressure. So 70, 110, approximately 110 over here, maybe 115, and here 70. So 110 over 70. When you measure the arm blood pressure, what you're really doing is you want to know is when is the aortic valve opening, okay, diastolic pressure. And then during systole, what is the, at the end of doing the contraction of the heart, the highest pressure that the heart is generating at that time. So it's a very easy way of measuring what's going on with the heart and how hard the heart has to pump. That's why we measure blood pressure. Not that complicated. But I want to make you that connection. So every time you record the blood pressure, oh, I'm not just interested in what's going on in the arm, and I'm actually looking at how the heart is working. Okay, very good. Move on to the next. Here's a Vickers diagram. Carl John Vickers is actually a fellow that put all of this together in one slide. His contribution, was simply that to put it all into one slide. EKG, we just talked about the left ventricle, atrial pressure, aortic pressure, the heart sounds, but he also made a contribution of listening the volume of the left ventricle, volume of the ventricle, how the volume changes. It goes stable and it goes down. The volume goes down during systole, then it starts increasing back up and so forth. And you also measure the aortic flow, how fast the blood flows. It flows very rapidly in the first half of the systole, and then not so fast in the second part. And then, of course, there's no flow.
So
The valve is
I,
closed.
here's something I have to throw this in, Dr. Limber. I keep waiting. I tell them all they need to learn the Wiggers, and I told them if anybody ever gets a tattoo, then they can just use that for their test review. But so far, no Wiggers tats.
No, that at all. Oh, gee, well, this is a perfect looking tattoo. No, so.
Yes,
Mm,
one of
absolutely.
these days.
Yeah. Yeah, yeah. No, you never know how things change. Yeah, that's a Wiggers diagram. And so, and it's very important to understand that as we go into the next, but we look at pressure volume loops here. Good. So I summarize it with this slide here one more time. And it's important. This is an important slide. But now that you understand the Wigger diagram, I simply pick the left ventricular volume, the heart sounds, and the left ventricular pressure. I did not list everything else. So I want to go through there one more time. Okay, atrium contracts. And then now the mitral valve closes. I have this heart sounds. Okay, oh geez. Have a sound occur. Now the pressure in the ventricle increases. But remember, mitral valve closed, the other valve doesn't open until then. So in this phase B, we have simply pressure that increase, but what happens to the volume? No change in volume. See, the volume is isovolumetric, iso meaning equal, from here to here, no change, iso. So here we have an isovolumetric, but we know we are in the contraction phase. We are in the systole. Systole is when heart contracts. So we have an isovolumetric contractions up till the point here where the aortic valve opens. Now the volume of the blood quickly decreases. We have the rapid ejection. Then here in D, as we saw from the Vickers diagram, initially very fast and then slower, slow ejection. In D, the ventricular volume decreases not as rapidly. Okay, now the aortic valve closes, so the pressure continues to decrease because the contraction is over. It decreases until the mitral valve opens. During this phase here, we have a closed aortic valve, and here we have a mitral valve that's closed up till here. It only opens here. So once again, we have an isovolumetric, but here it's relaxation. And then we have a rapidly filling of the left ventricle in this section F here. F there. And then in G here, we have the delayed, filling. Okay. So here we have all the phases A to G and in together. And we know exactly where the mitral valve opens, where the mitral valve closes, where the aortic valve opens, where the valve closes, and we have the heart sounds. So here we are in just listing atrial systole, isovolumetric contraction, rapid ejection, reduced ejection, isovolumetric relaxation, rapid filling, reduced filling. Then it starts all over again back from A. Those are the phases of one heart cycle. Okay, so I think that's pretty easy to understand here at this moment. I'm going to make, and now I'm going to plot it in a slightly different way. See, on the bottom, I don't have time like here. Here we have time, the x-axis here. Okay, I'm going to change that to volume. And I'm on the left side, I still have the pressure. We have pressure here on the y, and here we have the x, we have the volume. Follow me? Okay, so there's no time involved here, so we don't know how fast it goes. But we have the whole cycle put together in one graph. That's why we call this left ventricular pressure volume loop. It's a loop. It keeps going from A all over the B, C, D, E, F, results at A each time, and so forth. The A does not exactly correlate to the A that we had before listed here. I wish you would, but not. So whenever you want to find your way around here, I would like you to pay attention to this little bump. Whenever you see a little bump like this, it's most likely what? Anybody tell me what does it reflect? What's going on in the heart and atrium and ventricle and so forth?
Atrial contraction.
Absolutely, it's the atrium contraction. There's nothing else that looks like this. So then gives you a little tricky, slide or so. You think, I know, I get him. I know where I am with this guy. Exactly, atrial contraction. Now we're looking at the left ventricular volume. From here to here, how does the left ventricular volume change? How much does it change?
Doesn't change.
It doesn't change, exactly, Xander, very good. So that's why we call this isovolumetric. No change in the volume. The volume stays precisely here at 150, let's say. Okay, so at this moment, with isovolumetric contraction. At this point D, what happens to the aortic valve?
It opens.
It opens, very good. The aortic valve opens, of course, now the volume changes. The volume decreases. It goes from 150 closer towards 50 at some point, very rapidly to here, rapid ejection. And at this moment here, we have the aortic valve closing again, and the pressure drops precipitously down to about 5, 8, and the volume is again unchanged. So we have isovolumetric relaxation. Here we have rapid filling. The ventricular volume increases, goes towards the right, slowly goes to the right some more during the delayed phase, and then we have atrial contraction, then we isolate. So we have a whole heart cycle here going round and round. So here's a few questions here, which are easy to be able to understand. Mitral valve closes. Can somebody chime in which letter?
C,
Anybody? C, very good. Mitral valve closes right there. Aortic valve closes.
F,
F is right. Mitral valve opens.
A.
A,
A, very good. And then aortic valve opens.
D.
Yeah, will be D. Very good. You guys are amazing. All right, I think I'm done here. I guess you know this. Good. Okay, pressure volume loop. We will see how that helps us understanding what's going on with function of the heart. I just want to throw this in there too for those of you in the echo lab and those in the cat lab. Both of those, those whatever we just talked about is not just some kind of imaginary number terms. This is something you have to be familiar with. Isovolumetric relaxation. You can measure that with your Doppler in the echo lab. You can measure with negative dPdt, rapid filling and diastolic pressure. But you have more sophisticated measurements you can do with your echo machine, right? Peak mitral valve velocity, etc. You know more than I know about that. And then atrial contraction, you know about your peak mitral anyway velocity, pulmonary venous flow during atrial contraction. Those are all reasons why you're asked to measure those in the labs. Of course, in the cath lab, we are a little bit limited. When we have a catheter, we measure ADP pretty much all the time. Some catheters are allowed to measure DPDT. Here's how everything affects what's going on with the heart. We can conclude there's something wrong with energy that's the first thing that shows a problem in patients with heart failure. It's not the contraction, it's the relaxation. We know that. The early sign of ischemia is abnormal relaxation. Ischemia meaning lack of oxygen or energy to the heart muscle. Okay, throw that in there. So now what we have here, we have those pressure volume loops. This is done, in the old days in the animal at 1, 2, 3, 4, 5, 6, 7 different pressure volume loops. As you can see, the smallest one here has an end. Remember, here we are, we end diastole, remember? Then the mitral valve closes, the aortic valve opens, the aortic valve closes here. isovolumetric relaxation. It's not exactly straight, but you get the picture. So you see smaller ones, bigger one, and bigger one. What happened during this time? Well, as you can see, each time the end diastolic volume was changed. At this point was like 65. Well, this guy here is almost 110, maybe around 100. And you see, as that end diastolic volume increases, the stroke volume, which we'll see is the difference between this volume and this one, increases. So here we have what I need to explain to you, what's called end diastolic and end systolic pressure volume curve. I'm talking about a curve, about a line, okay? So here is where our end diastolic events happen on this line here, and that's why it looks like this yellow line. So this is our end diastolic pressure volume curve. In systole, it's very unique. As you see, all of those contractions, the seven that we just looked at, they all end up on one straight line if I connect to the point where the aortic valve closes. And that is not just coincidental. That is because that heart that is in a particular contractile condition, once it's finished its contraction, it's can no more. I'm exhausted. I did all my actin and myosin have done their job as how many that I used, and they end up precisely on one line. That line here is called the end. Okay, this is by the way stalling, but this line here is the end systolic pressure volume curve. It's a straight line. And that line, the shifting, that the pitch of that line or the steepness of that line is determines our contractile phase. So now I have my borders in diastolic curve and systolic curve. Within is where we are looking at how the heart function actually happens. Okay, this is what determines the contractility. This here is what determines our stalling principle, or Frank Stalling principle. You follow me this moment? This is probably the hardest slide in the whole talk here. This the second half to understand, but it's simple. It's what it is. This one is easy. This is a bit harder to understand, but this is exactly what contractility is going to be showing to us. Depending on how steep this line is, we know a heart is a good heart or is a bad heart or is a weak heart. Okay, so now we're going to go through this together. Look stylized a little bit. We have our end systolic pressure volume curve. We have our end diastolic pressure volume curve on the bottom. We have volume here again, and we have left ventricular pressure on the x-axis. So we have an isovolumetric. I lost my little A bump here, so I just made it straight here. So we have an isovolumetric contraction, isovolumetric relaxation, diastole relaxation, systole over here. The difference between this volume here and this volume here, that's how much blood left the pumping chamber. That's how much blood was pumped. The heart, as you know, does not pump itself to zero each time. It leaves about at least 50 cc's or thereabouts in the chamber. The difference is the stroke volume. And as you then relate that stroke volume towards your end diastolic volume, that's when it becomes ejection fraction. Usually about 55 to 60% of what's in the end diastole is being pushed out. And that's a normal number. It's not 100% ejection fraction, as you know. So remember, stroke volume is what I'm using stroke volume now to assess the heart function. Okay. So moving on. So now we're going to look at preload. How does preload affect our stroke volume? What I'm really doing, I'm talking about the stalling mechanism, where we found out that depending on the length of the sarcomere, depending on the length of the end diastolic pressure or end diastolic volume, it will affect my stroke volume. That's what Frank Starling says. Well, let's show me that. I'm going to show you here. I'm going to increase your preload from the yellow one. I'll push it way out here. So the preload is now increased from here to there. And again, we have isovolumetric contraction. At this point here, all factors being equal, i.e. the aortic pressure is the same, about 85. The aortic valve opens, ejection, it stops at that line. That's our end systolic pressure. And then you have isovolumetric relaxation, filling again. So the green heart cycle here clearly shows a bigger stroke volume. So increasing your preload, increase my stroke volume. The opposite, let's see here, Now I'm reducing my preload way down there. Remember, now we are below 2.2 micron on our sarcomere length. And what happens? By golly, the stroke volume is quite a bit smaller than the other one. This is what Frank Starling shows. End diastolic or preload. We call this preload. Easy way to remember preload means it's before the systole, before pre-systole or preload. That's why preload is an easier way to remember. So as you change the preload, you will inevitably affect the stroke volume. Okay, that's what this slide will tell you. Okay, let's talk about afterload. That's another new concept, what you need to remember about afterload is really what's happened after the heart pump. On the other side of the aortic valve, or the aortic valve included. Okay,
Can I
so
say something here for a second?
yes, please.
Yeah, the afterload is one of those concepts that I always kind of had a hard time getting through to everybody. So this is really important. Everybody listen up.
Yes, so that I usually try to tell folks, afterload to remember is you have a pump, okay, and I'm interested. What is after the heart, after the pump? Well, there is all the piping. There has to be pushed blood into the piping. That's afterwards, after the heart. So if you make it very hard on the pump, and I mean, where you constrict that pipe afterwards, the heart has to pump against that. Well, one way of constricting the heart is by changing your pressure. Your pressure is determined by your arterioles of your vascular system, as Darren will tell you later on. So the body contracts your arteries, and by doing so, the blood pressure starts going up and up and up. And if you have hypertension or blood pressure for many, many years, that puts a lot of work on that heart muscle. Okay, that poor heart for years and years had to pump against a very high pressure, and I wish that pressure would have been lower, is the heart telling us. But unfortunately, I don't know what happened, but the arteries were all contracted, and I had to work my tail off to get this blood going, and that is the hard work the heart has to pump. Okay, and that is called afterload. The afterload was hugely increased for that heart for 20 years. Okay, so whatever the situation, the condition after the heart pump, so to speak, literally, visually after the aortic valve for and also hypertension. So hypertension is the classic way of increasing your afterload. In fact, you will see me on the next slide, kind of distill it right down to the blood pressure, and more importantly to the diastolic pressure, because that's where the aortic valve will open. Okay, so preload, fine, we got that. There's the volume before the heart contracts. That's why it's called pre-systolic load, and the afterload is what's going to happen here later as we will talk. So there are some conditions that change preload. For example, if you have exercise, you increase your venous return from the legs and functioning muscle. If you have too much salt, retention in congestive heart failure, that increases your preload. If you give IV fluid in a patient intravenously, too much saline infusion, you end up with a high preload. If you have a heart that has a left ventricular hypertrophy from long-standing hypertension, then you will also increase your preload. In the contrary, is if you bleed acutely, hemorrhagic shock, if you take too much diuretics, if you have sepsis with severe vasodilatation, your preload drops. And you can imagine what is the situation if somebody has sepsis. How do they show up? If they have a bad fever, and what is their blood pressure? Blood pressure is low, vasodilatation. How is the heart? The heart pumps like crazy, but is not able to produce anything because the preload is so small, stroke volume is so small that the heart has to pump very, very rapid. So the heart rate is like 140, and it pumps like crazy. Blood pressure is 80 over 50, and the blood is not going anywhere. And it's not because of the heart is bad, it's because the sepsis, infection, your whole body infection with bacteria has dilated your arteries massively. It's like you took an overdose of blood pressure medications, essentially. And that, of course, then results in low blood pressure and severe vasodilatation, decreased preload, and very poor cardiac function, even though there's nothing wrong with the heart. The heart is perfectly fine. It's just they're not coordinated. the vasculature, pressure, and the heart pumping, they are not coordinated. They are disconnected. And that's why those people end up in severe problem when they are in an intensive care unit. Okay, preload we talked about. Let's move on then here, afterload. So afterload, you see me here in parentheses, blood pressure. And remember, what I'm going to talk to you about is this position right here, and that's where the aortic valve opens. If the aortic valve opens way up here, as we will see, it will significantly affect the stroke volume. Let me just go through this slide, and then we can have you ask more questions if it's not clear as far as afterload goes. Okay, so now I'm going to do what? I'm going to increase the afterload. Okay, so we start off here in that purple one. Could you see the pressure isovolumetric contraction? But before the aortic valve opened up here about 95, and this time, oh my gosh, the aortic valve is not wanting to open. I mean, okay, so I have to generate more pressure. Okay, more pressure. Still not opening. What the heck is going on? So the ventricle keeps going. More pressure being generated. No pressure. Oh, finally the aortic valve opens. Now we're talking about 120. Okay, and now of course the ventricle says I can inject my blood and fine, but remember it can only go to that line. And then we have the isovolumetric relaxation, and you can quickly see that stroke volume is much smaller here than the yellow one. So you see this problem here where the aortic valve is not wanting to open because that person has hypertension, has high blood pressure, puts a lot of burden on this heart. The heart is not able to pump blood. All its energy is being wasted, so to speak, in generating pressure. As soon as the pressure is high enough, yeah, then the aortic valve opens to overcome that hypertension, but at the big cost of a smaller stroke volume and the wasted of energy in this generating the pressure. So an increased afterload is highly inefficient for the heart to work. That's why we as physicians and you as technicians that working in the lab, if you see a high blood pressure, man, that guy, I mean, I'm sorry for you, you're not doing well. Your heart has to work really, really hard. And exactly. So the contrary again, if you lower the afterload, look at here. Now I'll make it really easy. So this green heart here is contracting, isovolumetric contraction, mitral close, isovolumetric contraction. And you said, wow, this is easy, this easy breezy here. The aortic valve really opens. I'm such a lucky guy here. I can pump the blood and oh wow, I have a huge stroke volume and I relax and I feel it again. So simply by reducing that pressure from 90 down to maybe 60, that heart has is very happy heart, and is able to pump a lot more volume. So here we are. As we talk about afterload, we talk about this point here, the pressure volume loop. If you see, there's a question about afterload being changed in this particular patient, one of Darren's question, you look over here. If he talks about preload, you look down here. What's going on? Up or down here? Up or down here? Volume high and diastolic volume slow. Afterload high, afterload low. Okay, so this is how we look at how the heart is able to pump. Then we're going to conditions that change the afterload. Of course, increase afterload. I just talked about it. Is hypertension. Okay, same thing happened to aortic stenosis. Now we're not talking about after the heart. Now the aortic valve becomes part of after the heart, so to speak. If the valve somebody has rheumatic aortic valve stenosis or just old age aortic stenosis, the pressure will be significantly higher on that left ventricle and the afterload is increased. Same times, decreased afterload, of course, blood pressure medication will lower the pressure. And then we talked about sepsis and then AV shunt. I'm going to leave that alone for now. Okay, so now we need to talk about contractility. And we already know contractility has something to do with catecholamine. And we know this end systolic line will be changed. For a heart that has good contractility, that curve is shifted to the left. Now our end systolic line ends up over here. And you can see what happens to that pressure volume loop and stroke volume. We have the same end diastolic pressure, same afterload. The only thing that's changed, contractility is now shifted to the left, and the stroke volume of this green heart now goes all the way over till it has to stop here at this line of the catecholamine influence, and now the stroke volume is definitely increased. Again, if the contractility is reduced, such as in heart failure, the curve is shifted to the right. the end systolic pressure curve is reduced. And now again, we have the same end systolic volume, same afterload where the valve opens, and that purple heart is only able to go to over here. And because the contractility is reduced, in this case, it's reduced because the patients may have had a heart attack, may have had a significant muscle damage, and so the contractility is reduced. And you see, this is a puny little stroke volume. That doesn't allow for too much exercise, and definitely not for running. Bloomsday, for example, although I'm not sure what's going to happen this year. But anyhow, so now you understand how contractility affects. So preload here, afterload here, contractility has to do with the shift of this end systolic pressure curve. Questions? Anybody? Please feel free to ask if any questions. So then I want to show you a couple of other slides here. What can we do then if I have a patient that is in this condition, stroke volume, let's say this is a small stroke volume, the contractility is reduced. So now that you know, we have three ways of helping that failing heart, okay? So let's just start with one of them. One of them, anybody has any ideas? Where should we start? Just staying the same sequence. Let's start
Change
with
to preload.
preload. Let's start with preload. Very good. So I'm going to change my preload, see if that will help the heart. I'm going to bump up that preload just a tiny bit to up here, and I'm leaving the afterload the same. This line obviously is limited because that's the condition the heart has. And yeah, sure enough, I was able to increase my stroke volume. Now, you may say, well, just keep going over here, even more stroke volume. Well, you could, but see what happens here at this point here. End diastole, the pressure is now 25, 30, maybe somewhere here. Well, that same pressure in that left ventricle is to be found where anatomically in that heart? If it's in the left ventricle in diastole, what's the next part of the anatomy that has the same pressure? Anybody knows? Next to the one before. Yeah, I just this
Left
Chinese.
atria.
I'm sorry, of course, the left atrium. So the left atrium has the same high pressure, 30. And what else has the same high pressure then? What's before the left atrium?
Would it be the pulmonary veins?
Pulmon.
The pulmonary vein have the same pressure. What's before the pulmonary vein?
The lungs.
The lungs.
Lungs, exactly. So that's the problem, right? So if you tell me, well, we just keep going here and just increase that end diastolic pressure, well, that heart is going to be pumping beautifully. Well, it does, but in the meantime, you can't breathe anymore. That high pressure that you just going up, remember the curve is a J curve, like we said in this Frank Stalling. That same pressure will also be felt in the lungs. And that's when people come in who have heart failure, what do they complain about? They don't complain my stroke volume is low. What do they say?
Pressure in the
They can't
lungs.
breathe.
They can't breathe. Exactly. So they can't breathe. So there's a high chance that they probably are, way up here on the high side. So first of all, we need to be able to make them breathe better. And I'm not so worried about the stroke volume. I'll need to bring them back down. In some cases, I need to give a medication that reduces that preload. And what is that medication would be, for example?
Diuretic.
Diuretic, exactly. Now all of a sudden, oh, doc, I can breathe. Because I just brought him back from that high pressure over here that from the left ventricle in diastole has been translated to the left atrium, to the pulmonary vein, to the lungs ultimately. And now the diastolic pressure is better, and now they can breathe. Now, here's the challenge for me then as a doctor. I don't want to keep going over here. All of a sudden, they can breathe beautifully, but now they can't do anything. They can't climb the stairs anymore because the stroke volume is too low. So you see how there's a very fine line, sorry. There's a very fine line where it's optimal. And you will be seeing that. You will see patients in the cath lab who have what's called a Swan-Ganz catheter. I can measure that end diastolic pressure by blowing a balloon up because that same volume of blood after the end of that balloon goes all the way to the left atrium, to the left ventricle, and I can figure out where are they on this curve. If they are down here, I better give them fluid. If they're way up here, oh, we got to give them diuretics. I want to find the sweet spot here where where they can breathe and where the stroke volume is still good. And that's done with a catheter. For those of you who work in the cath lab, it's one GANS catheter, and you will, the echo people will see them, when they do the echo in the ICU, for example. Okay, so that's preload. Very important in heart failure. We can change preload, and that's what I put down, changing as opposed to increasing. Sometimes we have to decrease it, of course. Yes, so we can change preload or we can help that heart. The next thing we can do decrease the afterload. Remember, we learned that if I decrease the afterload, the heart is so thankful. He said, "Thank you. I am so much easier to work. I can take all my energy by pumping blood as opposed to generating pressure." Imagine generating pressure takes energy, but it doesn't pump blood. All it does, it generates pressure. We need the heart to pump volume. So by reducing the afterload, we will also improve the stroke volume as you see with this slide. So those are the two main ones. Sometimes those two changes are not adequate. The patient is in the ICU and still can barely breathe, maybe a little bit better, but then what else do we have to do? The next thing is we have to work on the contractility. So we move that line over here a little steeper by giving them inotropic drugs, maybe digitalis, maybe dopamine, dobutamine, catecholamines, okay? Once we do that, then we see that that same you know, afterload and preload will now result in a higher stroke volume. That's exactly what we do. Preload, afterload, catecholamines, or even a combination of them. I haven't even made that slide for you, but you can imagine if we change the preload, lower the afterload, and change conductility, we get some significant improvement. And that's see everything we learn today, you all, has a very purpose. It's not just that Dan can ask you questions and has another test for you to do. It's mean, we can actually this is what we use, and you will be working in hospital settings or that's something that will be there all the time. I want to quickly switch gears to diastolic heart failure. Systolic heart failure, you see here an anatomical section. The heart is stretched out and dilated, pretty poorly contracting. There's a big heart scar here. There's not some muscle here. In diastole, it's quite different. Now we have too much muscle. We have hypertrophy. There's very little volume here. Okay, this patient would be somebody that had high blood pressure for 30, 40 years. Right? What happens during diastole, the heart failure, the curve is shifted up here. We have left ventricular pressure does not go down. You have abnormal relaxation and it's stiff. As soon as the blood fills it, it quickly rises the pressure. It doesn't allow for blood to be there. It quickly goes up. Okay, that's the stiff, abnormal relaxing heart because of diastolic heart failure. Systolic function is fine. Ejection fraction, wonderful, but the volume is very slow, very small. This is called heart failure with preserved ejection fraction, HFpEF. You will see that being used in clinical settings. Okay, so what does it look like for HFpEF for diastolic heart failure? This is our normal heart. Here's what happens. Because of diastolic thick heart muscle, the pressure does not gradually increase here as in this slide, it goes like this. It increases, but sooner up to a certain level of volume, the pressure quickly goes up because of that thick heart muscle. And as you can see in this case, what is the stroke volume of that heart? Well, end diastolic volume that's tolerable in the lungs where people don't have shortness of breath is about here. Okay, and uh, and then you see the stroke volume being significantly reduced compared to a normal non-heart failure with diastolic dysfunction person. Okay, then here's one more slide here I want to show with you, and that is how does that all relate? So we talked a lot about stroke volume. Okay, we learned about how the stroke volume is affected by preload. Well, preload is affected by venous return. We talked about contractility, how that affects catecholamines, stroke volume, and we know how afterload affects the stroke volume. If you take stroke volume, multiply by the heart rate, you get cardiac output in liters per minute. The cardiac output affects, of course, your arterial pressure. You have your carotid and aortic pressure sensors. The pressure sensor tells the brain, vasomotor cardiac centers, hey, this is what's going on, slow down or increase it. And this is the higher nervous center. We say, hey, I need to climb the stairs very rapidly, I'm late to go to school. So then we can take care of that, more catecholamine, and your stroke volume will be accordingly. And so you can able to run the steps. You see, everything we learn is restricted to here, cardiac output, but you have to always understand it's all connected in the big picture, the circulatory system, as you will learn in this class here with Darren, as he will talk about some of the other ones. So this is my summary slide then. We understand that we have the aortic and pulmonic semilunar valves, and we have the mitral and tricuspid atrioventricular valves, how they interact when they're closed and when they're open. That affects our cardiac cycle with the isovolumetric contraction, relaxation, and ejection and filling phases. We know where the heart sounds occur. First heart sound with closure mitral valve, second with closure aortic sound. We know what the pressure volume looks like, where the stroke volume is being generated. We definitely understand that preload affects the stroke volume. We also know the afterload is affecting the stroke volume. And then we know how to contractility affects the end systolic curve, and that also affects the stroke volume. How we can help the patients who has heart failure by using that information that we can measure, that is able to do with echo or with catheters to find where the need is to interfere and interact. So that's what I have here, and I really more than happy to entertain questions. We have time, I'm gonna at least 5 more minutes or 10 more minutes or so, and so anybody has any question, I can go back in the slides here, and give that to you. Please feel free to act to say I'm not gonna see you all. I wish I could see you all. I don't know, can I? Okay.
I have a question for you. Thank you for that. That was really very illuminating, Dr. Limegiver. Helps kind of tie a lot of things together we've been working on all year.
Mhm.
And when you're working with your preventative patients, you're trying to keep them out of trouble. Do you spend more time? Here's my question: do you spend like a lot of time looking at these echo diastolic parameters? Is that something that's really important to you? You kind of mentioned that as something new.
Yes. Yes, absolutely. Fundamentally there, the idea is we try to really be 10 years or so, 20 years or so before you start seeing those parameter change, like echo abnormalities and diastole and so forth. That's we really are hoping we will, ahead of the curve before it comes to the point where something is even is excuse me is visible with the echocardiogram. What I'm talking about then is, I'll come back to that though, to your questions. We talk about is most people you can figure out, are you a high risk for having problems, cardiovascular wise. And there are some risk scores which are out there, which have been developed for years and years. And if you plug yourself in, which includes your blood pressure, cholesterol, smoking, family history, lifestyle, are you overweight, you don't exercise, you sleep good, and you have sleep apnea and so forth. All of those are well-known risk factors that will eventually, over times, lead to problems in your heart. And the most significant one is sugar problems, whether you're pre-diabetic or diabetic. And that takes 20 years before people are diabetic. Most doctors do not pay attention of a little bit of change in your blood sugar, for example, and they say, you're fine. Well, 20 years later, you're not fine, and then you will tell doctor, I wish you'd have told me, why didn't you tell me that my sugar was a little bit, just a touch. It's like being just a little bit pregnant. Don't worry about it. It's kind of the same thing. So, and that's what I'm trying to help people to pay attention to, those little telltales that one can pick up. But your question about diastolic abnormalities, you're right. When people have ischemic heart disease, if we see that the circulation is not good, for example, when we do a stress echo, for example, that's, we may see some changes. The systolic function is good. The wall motion is fine and contraction is fine, stroke volume is fine, but we may see some of diastolic abnormalities, and the echo tech can look at that quickly, is able to maybe identify the diastolic parameters, because those are the first one. Those are the first one that do get affected by energy supply mismatch, supply and demand mismatch. So yeah, so you're all young and healthy, and I urge you all to to look at your health. Be careful. You got big tests and exams and big, beautiful, bright future in front of you, and make sure you take good care, of yourself. Forget the most people nowadays don't smoke anymore, which is wonderful. But blood pressure, everything that is, if you do everything right, you will not. There's no 100% guarantee, but if you don't do it right, yeah, you will have more problems. So keep that in mind, and just do what you can with diet and exercise, and don't stress, and use some mindfulness, and there's lots and lots and lots of things. So I'm really excited to be in that field. I understand, Aaron, that did you say that you're going to be next year? You won't be asking me anymore. Is that true?
Right. I think this is the, I'm gonna sail on down the road and turn the keys over to somebody else to run the ship.
Ah, well, that's what I was. That's why I want to tell you how much I enjoyed working with you on this. It was always a pleasure. You ran, a fairly tight ship, and you've created some great, people with futures, and that you've been helpful for, and I will miss that email sometimes in March. Can you do another pump lecture?
Yeah.
But I'm gonna wish you the very best. And you're gonna, in your next phase of your life, whether it's retiring or something else, or just simply focusing on something that you always wanted to do, I'm sure. And the rest of you, I wish you all the best. For exams is one thing. Remember, exams is just something to refresh your memory, but you got to look and keep the focus, your horizon on the long run, and you all will do very well, I'm sure. So yeah, it's been a pleasure. I always enjoyed giving the talk, and then we'll wish you all the best. That's what my last slide here. I think it is. And maybe you can read this. I can. That's what it takes.
Thank you so much for always being there for us. And these 2 hours really kind of, I told them, get ready, you're going to be in for a treat. And we kind of wish we could have you every week, but we get you once a year and we make the best of it. You did a wonderful job all those years and today as well. So thank you so
Thank
much.
you very
Dr.
much, Ben. All the best to you guys.
Thank you, Dr.
Thank you.
Thank you so much.
Okay.
Thank you.
Thank you.
All right.
Okay.